Okay. Well, Massimo, we are on Facebook right now. I'm going to introduce you to the audience, Massimo.
Thank you.
Thank you to you. Bueno, buenas tardes ya a todos. Les damos la bienvenida a este webinario de la Asociación Mexicana de Ultrasonografía, Crítica y Urgencias con su unidad de entrenamiento internacional en la ciudad de Guadalajara. Sean ustedes bienvenidos a este fantástico e interesante webinario acerca de la colocación de accesos vasculares mediante ultrasonido. Como ustedes saben, este tema es verdaderamente interesante porque actualmente en muchos hospitales la colocación de accesos vasculares por ultrasonido se ha convertido en una política institucional, en un estándar de cuidado en muchos hospitales. Como ustedes saben, hay mucha gente entusiasta tratando de colocar accesos vasculares mediante ultrasonido y cada vez hay más gente interesada en tomar cursos. Y precisamente es por eso que hemos traído y hemos invitado al doctor Massimo Lamperti. Él es un extraordinario médico italiano que se encuentra trabajando actualmente en Abu Dhabi, en Emiratos, en el Cleveland Clinic, allá en Abu Dhabi. Y él ha accedido de manera muy entusiasta en transmitirnos parte de su vasto conocimiento sobre el tema. El doctor Massimo Lamperti es un experto mundial en la colocación de accesos vasculares, por lo cual nos sentimos muy orgullosos de tenerlo aquí en nuestra asociación. Como ustedes saben, él ha escrito y ha dirigido varias guías y recomendaciones internacionales. Seguramente ustedes las conocen, las han leído. Una de ellas es la que se publicó en el 2012 en la revista de la Sociedad Europea de Cuidados Intensivos. Él, junto con otros expertos, publicaron estas guías que actualmente todavía seguimos utilizando, seguimos leyendo, utilizando la terminología, etcétera. Y él nos va a comentar incluso sobre algunas actualizaciones que están por venir acerca de estas guías. De tal manera que les damos la bienvenida a todos. Gracias por participar. Seguramente al final vamos a comentar, nuestra asociación tiene este curso, lo damos, incluso lo podemos dar en sus grupos, en sus hospitales, dentro y fuera de México. Tenemos un grupo preparado y además un curso bastante bien estructurado y organizado sobre la colocación de accesos vasculares. Y pues bueno, vamos a entrar de lleno al tema de este día con el doctor Massimo Lamperti, al cual le damos la bienvenida y agradecemos enormemente haya aceptado esta invitación. Massimo, thank you so much for accepting this invitation. We are really happy for having you. We are extremely happy. Thank you so much, Massimo. And let's get started with your conference, Massimo. Thank you so much. Welcome to Mexico once again.
Thank you very much. I've been to Mexico in 2010, so I'm very happy and honored to give you another talk. Ultrasound guidance for vascular access.
Thank you, Massimo.
So let's start with some disclosure. I don't have any real conflict of interest, apart that I'm really dedicated to ultrasound. And so what is the point and where we are now? So we are still in this phase where we have discovered mainly the big monolith as in 2001 Odyssey Space. And from this point, I want to show you that the monolith is still the reason why we are not using ultrasound, actually. So starting from the point in 2011, in 2014, in New England Journal of Medicine, there were some debate on why we're not teaching ultrasonography in our medical schools. And that point on, in most of the medical schools in the United States, there was a real switch in terms of education. So we have to stop, as this review said, to listen, and we have to look on what we are doing. And that is the shift from mainly the traditional medical teaching to the ultrasound medical teaching. So why? Because ultrasound has replaced the traditional auscultation, the stethoscope. And why? Because we can see what before we are just listening. And that's why we have to recognize the role of ultrasonography since the beginning of the medical schools. So there are two problems. One is that ultrasound can be not only diagnostic, but a procedural tool. And ultrasound vascular access is part of this therapeutic approach of the ultrasound. But we need an appropriate training. So say that there are different ways you can practice medicine. One is to use common sense, one to use the evidence. The third one is to use clinical practice in your clinical patients, and sometimes you have to reach a consensus. The use of ultrasonography, especially in critical care, has been mainly focused on different parts. So focus echocardiography, lung ultrasound, or vascular access. But if you look at point of care ultrasonography as the application of a bedside tool that can implement what we do and what we see in our patient, you see that there are a lot of applications. And different societies, for example, the International Federation of Emergency Medicine, point out that there is the need to have a specific curriculum in each of these applications that will bring to the have privileges and competencies that any physician can apply when he's starting to use ultrasound. There are a lot of courses around the world, the American College of Chest Physicians, and other courses by the American Society of Regional Anesthesia, or even a so-called ABCD ultrasound course, and that is just a 2-day course that are trying to give a proper teaching, but for a certain reason, they are not still able to provide a dedicated training and a dedicated certificate to this training. So my main question is, what are the main problems that we are still facing? First of all, when we are talking about vascular access, the assumption when we were doing a blind procedure for a central venous insertion or venous insertion was that we could have two different adverse events. One was a missed target, and that was causing repeated attempts before we were succeeding, or even a failure in the procedure, or a wrong target that was even more dangerous because he was related with pneumothorax or accidental arterial puncture. And what are the 6 postulates of the blind vascular ascension? The vessel is always present, is always in the same place, is always patent, doesn't collapse during inspiration. There are clear anatomical landmarks, and the vessels are always of good diameter. All these 6 postulates are wrong. Why? First one, the vein cannot be present because can even be a double, as in this slide we have a double AGV, or an hematoma that is hiding the internal jugular vein. It's not always in his anatomical position. Sometimes it's even medial to the carotid artery, and in a study done in 2007 by Dr. Mecken and Grau, they saw that there are different positions of the internal jugular vein related to the carotid artery, and the same has been even shown related to the subclavian vein, to the ciliary vein, and the femoral vein. The third postulate is the vein is patent, but sometimes we don't have a patent vein, but there is a thrombus inside the vein, and if you try to puncture the vein, you will not be successful. And sometimes the vein has not a good size. This is a small internal jugular vein or a large internal jugular vein. Both of them can be present or absent in even healthy patients. Or you have a specific alteration of the anatomical landmarks, for example, in this scar after a pterodectomy, or if you have a patient with a tracheostomy, in that case, the landmarks are completely disrupted. And finally, the vein is sometimes collapsing during inspiration, is moving and rolling around the other vessel, and these other vessels usually are arteries. So is common sense enough to abandon the so-called blind technique? Probably yes, because there is a lot of published evidence. All the meta-analysis published so far from 1996 till the last Cochrane reviews in 2015, all of them demonstrated that ultrasound guidance is associated with an increased success at first attempt, an overall success rate, lower cost, lower time, lower number of repeated attempts. And the most recent guidelines published, for example, in 2006 by the Association of Anesthetists of Great Britain and Ireland, declare that ultrasound guidance should be considered the new standard for internal jugular vein, subclavian vein, axillary vein, and so on. But there are different positions. The published guidelines, the one I published in intensive care, and the ones published by other societies as the American Society of Anesthesiology or the CDC, they have different positions. Why? Because most of the times they were more relying on political recommendation, suggesting that ultrasound guidance should be used whenever possible in internal jugular vein or whenever possible in children, or the American Society stating that whenever the ultrasound machine is available, you should use, but not considering when this is not available, what you can do. All these were more related to political or strategical recommendation more than an evidence-based approach. So far, the only guideline that was based on the grade process and with an accurate evaluation of the studies according to meta-analysis was the one that we published so far almost now 6 years ago in intensive care medicine. Why there are so many differences? First of all, because so far, even some of the studies that were published didn't have so many patients. So the population of patients, especially the pediatric population, was very poorly represented. And most of the outcomes were so different because there were no common outcomes in different studies. So the publication that we did so far in 2012 evidenced that there were, first of all, some definitions, and we established that while ultrasound guidance, all ultrasound guided procedures are the way to follow in real time the needle entrance till when the target is reached, mainly and the target is the medial portion of the vessel. Ultrasound assistance is just a guide, but not is not following in real time the needle pass, and it can be associated with the same rate of complication that we had with the blind technique. For this reason, ultrasound assistance in 2012 was completely abandoned in the current practice for ultrasound guidance. And we define even some basic terminology as the definition of short axis or transversal view, long axis or longitudinal view for a vessel, and oblique or transverse view. There were some, first of all, some major issues. First of all, as I told you, there was the clear definition of ultrasound guidance and not ultrasound assistance as the only procedure to be followed for performing an ultrasound vascular access procedure. And we even stated that it was mandatory to perform a vascular exam before choosing the vein where to insert the vascular access. Another important concept that came out from the consensus was that we have to choose even which kind of catheter, especially if we are placing a big catheter in a small vein, and especially for PICC lines that are placed in deep peripheral veins of the arm, and sometimes the catheter to vein ratio that should not pass the 30% is overpassing, creating a problem to the patient in terms of developing a deep venous thrombosis. And there are even some new concepts about how to evaluate. There is a systematic approach on a central vascular placement that has been named by myself and my colleague Mauro Pittiruti, RACEVA, or Rapid Central Vascular Access. So this acronym has been recently published in the Journal of Vascular Access, and in the next few months you can download the publication that has been produced by my colleague Mauro Pittiruti. And there is even a new acronym called RAPIVA, or Rapid Peripheral Venous Access, that I'm going to publish in the same journal in the next few months. Why we are using a systematic approach to choose the best vein and the best catheter? Because in a regular case, the systematic evaluation can help us to choose a central or a peripheral vein, but especially in difficult cases, we should be proactive to avoid to lose all the veins that are important for our patient. The RACEVA is designed, first of all, to teach the different ultrasound-guided approaches for the central vein, and to help the operator to scan systematically all the possible venous options. How it works? There is a first step. The probe should be placed in the mid part of the neck in order to visualize both the internal jugular vein and the carotid artery in short axis. So this is the first position of the RACEVA. And in this case, we have an ideal position for the out-of-plane puncture of the internal jugular vein. Or we can even use the same position in case we want to use the internal jugular vein in puncturing in an out-of-plane approach. The second step is to slide the probe down to the neck in order to visualize the lower tract of the internal jugular vein. And so in this case, we will be able to approach an in-plane puncture of the internal jugular vein till the subclavian artery, and we have to visualize a distal valve of the internal jugular vein that is called Tebesius valve. And this sometimes is patent, sometimes it's not, but this is something that we should be able to see in order to avoid the valve when we are puncturing the internal jugular vein. The third step is to go down again and in the neck and to tilt the probe so that we can visualize one of the biggest veins that we have in the supraclavicular area, that is the brachiocephalic vein, and that is shown in long axis. In this case, we can approach the brachiocephalic vein in long axis, and it is quite useful, apart in obese patients where sometimes this vein is very difficult to visualize, but in healthy patients can be a different approach and far from the pleura, because as you see here, that is the pleura, that is the entrance of the needle, and the needle in plane is very far in order to puncture the pleura and to create a pneumothorax. And finally, we slide the probe laterally in order to see and visualize the subclavian vein, and more laterally the subclavian artery. And in this case, we can avoid the puncture of the pleura in order to visualize in plane the needle entrance in the subclavian vein. And finally, we go below the clavicle in the third lateral of the clavicle, and in this case we can visualize both in short and long axis the axillary vein. So remember that the axillary vein is the only vein visualized below through the ultrasound guidance. The subclavian vein by ultrasound guidance cannot be visualized and even punctured in an infraclavicular approach. So all the studies that have been published so far, talking about subclavian vein cannulation with an infraclavicular approach, were relying on the visualization of the axillary vein and not the subclavian vein. And finally, we rotate the probe clockwise, anti-clockwise, and visualize the axillary vein in long axis. So the RACEVA mainly is not only a systematic approach to the ultrasound-guided vascular puncture of supraclavicular and infraclavicular vessels, but is taking in consideration even 6 different criteria. First is the caliber of the vein, the depth where the vein is, the collapsibility during breathing of the vein, the compression by arterial pulsation, the closeness to dangerous structures as the pleura, and the convenience of the access site. Let's examine, for example, the caliber of the vein. Sometimes the vein is too small to be cannulated, especially if you have to place a dialysis catheter. And the depth of the vein can be important because sometimes you have very superficial or too deep veins that can be difficult to puncture and cannulate. Or sometimes the collapsibility during breathing, especially when you have to puncture the axillary vein or internal jugular vein, can make you avoid the choice of puncturing the veins in order to avoid deep venous thrombosis after the catheter is placed. Or the vein can be compressed by an artery, and in this case, you can accidentally puncture the artery. Or is too proximal to the pleura, and in this case, you should avoid that approach, and you should use a safer approach for the patient. Or even the convenience, because sometimes, especially in the neck area, these catheters are not convenient. They are very dangerous for the patient. There is no risk of infection. It's better to place the catheter in an infraclavicular area where there is less risk of infection for our patients. And finally, I will just show you the Rapeva. This is again a systematic approach in order to visualize all the veins in the deep veins of the arm where you can place a PICC line or a midline. The approach starts with the cephalic vein at the elbow. You then go, you perform a kind of diverted C in order to visualize first the brachial veins, then the basilic vein, then you go back to visualize both the basilic and the axillary vein, and you go to the axilla to visualize the axillary vein to the conjunction with the cephalic and going then to the subclavian vein. So the Rapeva is more dedicated for PICC line insertion, but still can be useful in order to check if the PICC line is going to the internal jugular vein or is going to the right place in the junction between superior vena cava and right atrium. What is new? That's the news. So Perseus is the new guideline. I'm very proud to be one of the members of the European Society of Anesthesiology who is in charge for the writing of this guideline. Why Perseus is different? Perseus will be the perioperative use of ultrasound and will be mainly focused on the main and commonly used procedures for ultrasound in the OR. One is vascular access, and the second one is peripheral nerve blocks and neuraxial blocks. There will be two different definitions for a vascular access device. And this definition will be CICC, so a central inserted catheter, when a cervicothoracic approach is used, and so we will be divided in supraclavicular and infraclavicular, a PICC, peripheral inserted catheters, FICC, femoral inserted central catheters, and peripheral AV, peripheral inserted venous catheter. The first three, CICC, PICC, and FICC, all of them will have a central location of the tip. And for this reason, they will be defined central catheters, while peripheral AV will not have their tip in a central position. For this reason, the first three can be used for any kind of drug, while the peripheral AV cannot be used for every kind of drug. For example, the use of vasopressors. These are some preliminary results that are coming from a meta-analysis that we have done so far in Perseus. As you see, this is the overall success for ultrasound versus other technique for internal jugular vein cannulation in adults. And as you see, the ultrasound is in favor, so it's clearly beating all the other technique. And these are the grade pro that we use. And for example, if you use ultrasound, the overall success will create 147 fewer complications every 1,000 cannulation. And the rate of major complication will have 84 fewer complications every 1,000 insertion of the catheters. Going to other outcomes, we even consider the time to cannulation. You spend almost 2 minutes, 1 minute less. You have a few seconds lower than other technique, but the first time success, so the time you spend to have a correct approach is 250 seconds fewer every 1,000 cannulation. So in this case, you will have a first-time success that is quite convenient when you are to place internal jugular by ultrasound guidance. And what about the subclavian vein? While there were not so many papers, now the evidence is quite convincing. And even the big difference between Perseus and the last guideline by Cochrane is that it is now clear that ultrasound guidance is favoring the reduction of complication and overall success compared to other techniques. And again, if you look at the subclavian vein cannulation, the rate of major complication, you will have 31 fewer complications every 1,000 procedures performed. Is the new evidence enough? Probably no. As I told you before, one of the main reasons that this guideline has been created is to create a learning curriculum and a privileging certificate. So there are already some guidelines. One of them was published by Nancy Moore and myself in 2013 and was related only to the definition of minimal requirements for training in the insertion of central venous access devices. But there are other guidelines by the Royal College of Anesthesiologists or the American Society of Regional Anesthesia. All these guidelines were very, very vague in terms of defining which was the curriculum and most of all who should be considered the instructor. So because we have a lot of courses around the world, but we should define even why these instructors are teaching to the different trainees. And the guidelines that we published so far in 2013 was the first one who was trying to dedicate an important part to an objective rating scale and how the tutoring and the tutors should behave in order to be considered privileged and credentialing the different trainees. But in 2014, this paper coming in critical care demonstrated that when residents are trained by using ultrasound only, that's not enough, mainly. The study was done in a prospective way, analyzing ultrasound guidance versus landmark, and the trainees were using first ultrasound guidance, and then they had to perform 10 landmark technique. And ultrasound was performing better than landmark technique, but by itself, it was not sufficient to avoid a landmark treatment. So that's why we should keep in our curriculum still some part of the basic acknowledgement of the landmark and the surface techniques. Let's go beyond ultrasound vascular access and why we should not use ultrasound for vascular access, because we can use the ultrasound not only when you place the catheter, but when you have to check where the catheter is. And by this study that was done almost 4 years ago by Dr. Kim in Germany, they defined the use of a microconvex probe to check the tip of the catheter and the guide wire inside the subclavian vein and the superior vena cava. and they concluded that it was more accurate and less expensive, even in terms of time, than the traditional chest radiograph in order to check the tip of the catheter in the right position between the superior vena cava and the right atrium. Another part of the future is that now we are going to use different devices. There are already a lot of companies distributing Wi-Fi probes, and now the future is to have not only one probe, but to have one probe with different specification, so a phase array probe, linear, microconvex, and just a tablet that can show the pictures that we need. So this is mainly the future, and this is not enough, because some time ago, I was involved in a blog with a very harsh discussion on the use of ultrasound vascular access. And I was defending my position just with evidence. And I was very surprised because in that time, Dr. Bezzani, who is a friend of mine and who published a very nice paper regarding the use of ultrasound and echocardiography to check the tip of the central venous catheters, was still defending the use of the blind technique in order to teach. That is a very, very weak defense, because with all respect, nowadays it's very difficult to defend this position from an evidence-based point of view, as I showed you before, because now the evidence for every single point, especially related to vascular access, and I'm now including even arterial line placement, both in the femoral artery and in the radial artery, is clearly in favor of ultrasound guidance. So I believe now, ethically speaking, if you have an ultrasound guidance in your hospital and in your room, and you are not using that, and if you are trained, that is ethically something that is difficult to defend in terms of our patient safety. So my keynotes are that now ultrasound is the new standard of care for both central, arterial, and deep vein cannulation. It's a cost-effective procedure because, as I showed you, is reducing complication, is improving success, and our patient is punctured very few times compared to other techniques, or sometimes just with one shot. But training is a must. Without training, we cannot conclude that, and we cannot even give the privileges to allow people to proceed with the ultrasound guided procedures. Thank you very much. And if you will have time, I will host you in Abu Dhabi to make a visit in our wonderful hospital. Thank you.
Thank you, Massimo. Thank you so much. We really appreciate your fantastic presentation. Let's move on to the questions and commentaries, Massimo. I'll speak in Spanish for a while.
Yeah.
Muchas gracias a todos por acompañarnos. Bueno, vamos a pasar en este momento a comentarios o preguntas que tengan respecto al tema. Sabemos que el uso del ultrasonido para la colocación de accesos vasculares ha ido incrementándose en su popularidad. Sin embargo, como el doctor Massimo ha comentado, bueno, pues es muy importante el entrenamiento, y justamente es lo que ahorita vamos a comentar respecto a cuántos procedimientos quizás sean necesarios para lograr una curva de aprendizaje adecuada. Hay varias preguntas respecto a esto. El doctor Gerardo Montes Amaya levantó en este momento la mano. Le voy a dar audio al doctor Gerardo, ya sea que no sé si quieras, Gerardo, hacer la pregunta. ¿Dónde estás? Bueno, ya sea que quieras hacer la pregunta directamente o bien a través del chat. Estoy en este momento dando audio, Gerardo. Si gustas hablar, en este momento puedes hacerlo. No, parece que tiene apagado su micrófono. ¿Me escuchas, Gerardo? Bueno, parece que no. Massimo, we would like to know about the training. Massimo, as we have commented in past minutes, for us it's very important to know and to know your opinion about the learning curve, Massimo. How many procedures do you think is necessary to achieve proficiency or to be with the necessary quality of training in order to place this ultrasound-guided vascular access? Massimo, what's your opinion about the learning curve?
So we did a consensus because you know, there are different papers with different positions, and so far no one was able to provide an answer. So mainly the consensus that came out from the expert opinion was that we should have at least 50 procedures ultrasound guided supervised, and some of them should be even proctored. So there should be a direct observation from the so-called instructor in order to provide and even correct the trainees in order to avoid the trainee to perform big mistakes. And after that, so for specific approaches, for example, for the axillary vein or for a pediatric patient, there is an increased number of procedures that we were suggesting. So, but apart of the magic number, because everyone is trying to try to have a number, we should even consider the training as a whole. So not only the successful positioning, but even the outcome. So we should not have patients who are developing infections because we are not following the maximal barrier precautions or the correct choice of the vein. So we should have a proactive plan before we place the catheter and after we place the catheter. So one of the main risks is that you place the catheter and then you leave the patient and the catheter. And that is one of the big problems that we are still facing. So for this reason, whoever is in charge for this, not only to teach how to do the procedure, we should even teach how to do properly the procedure in his wall. So from the starting point till when the catheter is out from the patient.
Okay, Massimo, thank you. I'm going to read the question from Gerardo Montes, Massimo, en Spanish. Él dice, ¿qué acceso es el mejor para asegurarse digamos que el acceso más adecuado en un neonato? Massimo, what in your opinion, what is the best place for insert a catheter in a neonate patient? What is the best place for you?
So there is so first of all, you have to check with ultrasound which is the best catheter for the patient. But let's say, so while for adults, it seems that especially for long-term catheter, so if you have inserted a central venous catheter for a longer time, the axillary vein seems to be the winner. For the neonate, the bigger vein since the day of birth is the brachiocephalic vein, because the brachiocephalic vein has, first of all, a fixed diameter that is bigger even the internal jugular vein. The only problem of the brachiocephalic vein is that it's quite near to the pleura. For this reason, you have to use a special probe. You have to use the hockey stick probe, because this is the only way to visualize properly the brachiocephalic vein and to perform the procedure with an in-plane approach.
Thank you, Massimo. Well, another doctor is wondering, he says in Spanish, ¿cuánto debe de saber el médico especialista no radiólogo de las bases de ultrasonografía para estar bien entrenado e incluso certificado en la colocación guiada? In English, Massimo, is do you think that the non-radiologist physician should know about the general ultrasound before to insert or to be certified in the vascular access procedures. What's your opinion?
Yes. So no. So the guideline is quite clear. So there should be what is called knobology. So mainly or ultrasonology. So first of all, but all this part can be done even with an online course. So the theory of and the physics of ultrasound is part of the teaching. But mainly what is most important is to know the normal and the abnormal ultrasound anatomy, and then even to practice with healthy volunteers in order to understand what is the normal anatomy, and then in patients you can even practice on abnormal anatomy. So this is something now that with the technology, with the YouTube, with the webinar, you can even easily do even online. So you can change the way you are teaching, because one of our colleagues, Linda Kelly, who is a teacher of nursing in Edinburgh, in Scotland, is doing online courses for central vascular access placement. And while she is working in Edinburgh, she has 17 different locations around Scotland where she's teaching with a web camera, while the trainee is doing the procedure. So now with the technology, we can really change the peer-to-peer presence, because I'm now in Mexico virtually. So that's why the technology can help us to correct online what the trainee is doing. And there is not anymore a barrier, because with the technology, we can follow our trainee even at long distances, and we can even avoid the trainee to do big mistakes. Or if I collect, I just give you an example. Last week, I had a very bad pulmonary edema in a patient, and I collected the lung ultrasound with a lot of comet tails, maybe the best I have ever collected in my life. And I will use this as a training. So mainly you can collect normal anatomy and abnormal anatomy to teach to everyone who is involved in ultrasound.
Exactly. Thank you, Massimo. This is a very, very important point. And Massimo, as you know, we can visualize a lot of the complications after the procedure. We can use the same probe to evaluate the complications. Could you please comment something about this? And if you want to comment with slides, or I don't know, can you please let us know what is your opinion about the visualizing complications by using the same probe after the procedure?
Let me check if I can give you. I will share my computer, so I will give you. So the ultrasound can be used for even in order to check the immediate complication after a central line position. So since a long time ago, when we started with the courses with ultrasound, we started checking the complication. And I will show you some of the possible complications you can detect. You can detect, first of all, if you have both a pneumothorax, but even a hemothorax. And just a second. Are you able to see my screen?
Yes, of course, Massimo, of course.
Okay. Yeah.
You only have to open the slide.
Yeah. Okay. So the mainly the ultrasound can just can you see the slides?
No, only click share the green square or something.
Just a second. Yeah, no, they are not in PowerPoint. Just
no problem, no problem.
Mainly, but what I want to tell you is that the difference is that with ultrasound, you can first of all check the presence of a pneumothorax, and the pneumothorax is the main complication you can detect, and especially for the anterior pneumothorax, is more reliable than any other. Are you able to see now?
No problem, Massimo. Only share. Yes, if you want, only click the lower part of the screen. There is a button to share.
Yes.
Yes. We already.
Okay.
You can see your slides.
So mainly, what I wanted to show you is that you can check this kind of complication, and there are a lot of artifacts that you can use in order to check if the pneumothorax is present. So both you can see with the different points of view of the chest with ultrasound, if there are these different signs. You can see if there is absence of lung sliding, if there is absence of postpartum, if there is absence of B-lines, and if you can check if there is a lung point. If you have all this present, the accuracy and the presence of a pneumothorax is 100%. So then sometimes you can even check if there is an effusion after a central line placement. In that case, if there is absence of lung lining and absence of postpartum, but you have B lines, but you have the presence of an effusion, that can be the sign of an pneumothorax. That is even worse, because sometimes is not the first sign, but is the second sign that is appearing when you have especially a subclavian artery puncture. And with the group in Milan, we starting using and analyzing these different signs, and we came out with a final algorithm that I will show you. So if in case we have a pleural sliding positive, we don't have a pneumothorax. But if we don't have pleural sliding, we don't have postpartum, we don't have B lines, and we have a lung point, that is a pneumothorax. If you don't see the lung point, sometimes you don't only have a pneumothorax, we have a massive pneumothorax, and that can happen if you are puncturing multiple times the chest.
Okay, Massimo, thank you so much. We really appreciate your slides, Massimo. Well, one physician is wondering if you think, Massimo, if it is necessary an chest X-ray after the replacement of a catheter. In your opinion, do we need still the chest X-ray?
No, I abandoned to use chest X-rays for pneumothorax and for detection of the tip of the catheter, since when I had an ultrasound where I could see the tip with a phase array probe. Even with a microconvex probe through a subcostal view, you can see the tip of the catheter in the inferior vena cava, and with a bubble test, you can correct correctly visualize the position of the tip of the catheter. So in that case, even for the check of the tip of the catheter, it's possible to do that by ultrasound.
Oh, okay, Massimo. And even if the tip of the catheter is not in the superior cava vein, can we see the tip in other vein, not necessarily in the superior cava vein? For instance, in the jugular vein, can we visualize the tip of the catheter?
You can be. Sometimes the catheter is doing a reverse loop, and if you don't visualize the catheterization, so the correct position of the catheter, you have to check where is the catheter tip. So you can sometimes, the catheter can go from the internal jugular vein from the right side. It can go on the left side in the subclavian vein on the left. Sometimes it can go in the axillary vein in the right. So there are different locations. Mainly, if you don't visualize the catheter in its correct position, you have to check where the catheter is. And with the ultrasound, you can just have to scan the vessels, and finally you'll find the location, just injecting a small quantity of saline in order to see the movement of the bubbles inside the venous circulation.
Okay, thank you, Massimo. And well, Massimo, there are some members of our group. They are inserting the catheters by in the brachiocephalic trunk, and they are doing certain experience by doing this procedure and inserting the catheter in the brachiocephalic vein, and they have noticed that for them they say that it is even easier than the subclavian vein. And even it can be safer in some circumstances. What's your opinion or your experience about placement catheters in the brachiocephalic vein?
The brachiocephalic trunk is safer than internal jugular vein, and you can. So when I have to place a catheter for long term, so I mean, if I have to leave the catheter for 3 to 6 months, one possibility is to mainly use the brachiocephalic trunk as an insertion point, and then to tunnel the catheter here in the chest. So as you can do with Hickman catheters or Grosjean catheters, or even if you want to spend less money, you can even tunnel a PICC line by puncturing the brachiocephalic trunk and then tunneling the catheter here. That is a safer zone, especially if the patient has a tracheostomy. So most of the patients requiring tracheostomy, they have problems related to infection of the central venous catheters, because the tracheostomy is quite near to the central venous catheter. While if you use a catheter that is where the exit site is far from the tracheostomy, you have less risk of infections. And this is something that you can easily do by cannulating the brachiocephalic trunk, but then tunneling the catheter exit site in a place far from the initial puncturing puncture site. So that's it, another concept that is puncture site and exit site. So yes, both of them can be considered safe. An exit site can be considered safe, but is difficult to reach. And a puncture site can be safe, but unsafe from an infectious point of view.
Okay, thank you, Massimo. And Massimo, what's your opinion about the challenges that we are facing currently in our hospitals? And what can you tell us about the main challenges that we are facing, maybe worldwide, Massimo? So,
as you know, even here in Abu Dhabi, so the financial crisis is facing every healthcare system. So there is, from one side, the need to save money in healthcare, and as you know, the American healthcare system is one of the most expensive in the world, and say that the average outcome is not what you should expect from a very expensive system. So in Europe is the same. So there are a lot of financial constrictions that are trying to reduce the cost for healthcare. But let's talk about something that we should more focus, that is the outcome. So if you create one complication in one patient, you increase the length of staying of this patient in the hospital. So there is a very nice study that's been published now more than 15 years ago by Dr. Calvert and Dr. Hind in UK. And they demonstrated that if you use ultrasound, it's very simple. You reduce the risk of complication as pneumothorax, hemothorax, and then you reduce the cost. So the more than cost cutting, where you just cut and you have an immediate result, you have to do cost saving. Then the cost saving you don't see immediately, but you see in 1, 2, 3 years. That's why once you have to convince your hospital to buy technology, is because they will not see the immediate result, but they will see the long-term result in terms of outcome. So their patient will stay less in the hospital because, first of all, you are able to do the procedure safely. You are able to diagnose a pneumothorax without chest X-ray. And this is a net reduction of cost. If you calculate how many chest X-ray you have to do just to check if you have a consolidation, a bronchogram, or if you have done a recruitment maneuver in your patient, you can do that the same by using an ultrasound machine that has only one cost when you buy the machine, and then that's it, because the cost of the machine is already absorbed. So this is something that you can easily convince. You say, I bought the machine, but I'm using as a stethoscope for every single patient. If you use the ultrasound just as a tool for some patient, is not cost effective. That's why for every single cannulation, you have to use ultrasound, because there is where you have the advantage, where you spend less money, less time.
Okay, thank you, Massimo. I really appreciate it. Well, I'll speak in Spanish. No sé si alguien más quisiera hacer algún comentario. Tenemos en la audiencia a nuestro coordinador de la Unidad de Entrenamiento Internacional de WinFocus Guadalajara, Quetzal. No sé si quisieras hablar, tengo el audio activado, si quisieras hacer algún comentario, si estás en ese momento disponible, me gustaría escuchar tu opinión y tu experiencia. Quetzal, no sé si estás ahí. O parece que no. Arnulfo, si gustas hacer algún comentario, tienes activado el audio. Arnulfo es el presidente de nuestra asociación. También si quisieras hacer los últimos comentarios, Arnulfo, antes de cerrar el webinario. Bueno, parece que no han podido hablar. Bueno, Massimo, we really appreciate your attention. Thank you so much for spending part of this time with us. And I don't know if you want to say something for some last commentary for our audience in all Latin America and Mexico people, Massimo.
So I'm very happy to be part of this webinar because when I've been in Mexico and I met even people recently from Brazil, I know that all Central and South America is enthusiastic with ultrasound. And I'm so happy that now there even are national and local societies who are supporting the use of ultrasound in anesthesia and intensive care. And I will be happy to support even in the future these initiatives.
Yes, thank you. Quetzalcóatl, ¿estás ahí? Quetzal, si gustas comentar algo.
¿Me escuchas, Juan?
Sí, te escuchamos perfectamente, Quetzal, gracias.
Gracias. Pues la realidad es que me parecen bastante acertadas todas las propuestas que dio el doctor Massimo Lamperti, sobre todo por el cambio de paradigma y la posibilidad de migrar a otro concepto más claro de estándares de tratamiento. Yo creo que la perspectiva actual es darle seguridad al paciente, y la mejor forma de hacer eso en el escenario de los accesos vasculares, sin duda alguna, es utilizar la herramienta como eso, ¿no? Una herramienta que auxilie y que logre disminuir la cantidad de accesos vasculares o de punciones que necesitemos para colocar un acceso vascular y disminuir la cantidad de complicaciones. Eso me parece vital. Como organismo, ¿no? Como asociación, yo creo que una apuesta fuerte pues, ha sido tratar de capacitar a la mayor cantidad de personas, pero me parece que las escuelas que están formando actualmente especialistas, pues se deben de enfocar en ese escenario, ¿no? Poder capacitar a sus residentes, a todas las personas que están en entrenamiento, en el uso adecuado del ultrasonido, con la posibilidad del día de mañana, pues que esto esté incluso hasta legislado, ¿no? La colocación de un acceso vascular central siempre debiera ser con guía ultrasonográfica y dar seguridad completa al paciente que lo va a recibir.
Gracias, Quetzal. ¿Y alguna pregunta en específico sobre los programas de entrenamiento o certificación hacia Massimo?
Nada más comentarle ¿me escucha él ahorita?
Sí, sí, te está escuchando perfectamente.
Okay. Thank you so much, Dr. Massimo. We really appreciate your talk. And I would like to know if you think that all the schools that are training physicians, specifically residents, must use the ultrasound as a tool for the collocation of central venous access. And if the board certification must include the knowledge of this tool all around the world.
The answer is yes, and now the answer is not really yes, it's mandatory. So especially for the new generation, so we are not talking about only residents, we're talking about medical students. So the medical school now is changing the paradigm and to teach both the anatomy with the landmarks in a different way. You know, now we are talking about three-dimensional ways of teaching anatomy, surface anatomy, organ anatomy, liver anatomy. So now with a pair of goggles, you can just split the different layers, muscles. You can just keep the lung and split out the chest. So the way even the regular anatomy is now teach and learn in the medical schools is different. And that's why if the residency programs are not up to date, the risk is to have medical students with a very good preparation in ultrasonology, and then this the new generation of anesthesiologists and intensivists will have a gap. So that's why all the medical schools and even the universities will have to be prepared to teach in a new way the point of care ultrasound, not only vascular access, but in general point of care ultrasound, because this is the new stethoscope. And so as I learn from my teachers how to use a stethoscope, now from listening, I have to teach how to look.
Exactly. Thank you, Massimo. Bueno, pues muchas gracias, Quetzal. No sé si hubiera algún último comentario. No, parece que no. Sí, Massimo. Y bueno, realmente a mí me gustaría simplemente agregar que, bueno, hay mucho entusiasmo actualmente por la colocación de accesos vasculares a través del ultrasonido, pero quizás uno de los retos que también estamos enfrentando actualmente es la carencia de estos equipos en nuestras unidades. A pesar de que cada vez hay gente más, desafortunadamente no hemos encontrado en algunos casos en nuestros hospitales la posibilidad de realizar estos procedimientos debido a pues, la carencia de estos aparatos. Bueno, pues les agradecemos a todos su participación. Massimo, are you there? Still are you there?
Yeah.
Okay. Yeah. Okay, thank you, Massimo, for all your attention. Thank you for participating with us. We are really happy. Well, before finish the webinar, Massimo, you are invited to Mexico, and hopefully someday on the future we can visit our country in order to
thank you very much.
Certifications and so on. Massimo, thank you so much And do you want to say the last words for the audience, Massimo?
No, it's fine. So I'm very happy that I could give not only my opinion, but even some of the new updates. And I hope that by the end of this year, there will be the PERSEUS guidelines published in the European Journal of Anesthesiologists. I hope that even in the future that there will be a common guideline between anesthesiologists and intensivists in order to have a common vision when we have to use the ultrasound and when we have to use a common curriculum for teaching.
Exactly. Thank you, Massimo. And well, I'm going to finish the webinar. We really appreciate your attention, Massimo, and see you later. And thank you for spending part of your time with us. I know in Abu Dhabi it's 10 p.m. Yeah. So I really appreciate your attention. It's Saturday for you also, right?
Yeah. But tomorrow we are working because we are our weekend is already finished.
Okay, thank you so much, and see you later, Massimo. Thank you for being part of this webinar. Thank you so much.
Thank you. Bye.
Bye.